Welcome everyone to today's session of Head and Neck Cancer Key Survivorship Issues, led by Dr. Dennis and Lindsay Morales. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of the session, your questions in the chat will be used to moderate our question and answer. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Dr. Dennis and Lindsay.
Hello, everybody, and thanks for joining us today. It's really a pleasure to be here. As you may know, I am a head and neck oncologist at Dana-Farber Cancer Institute. Lindsay Margolis is one of our nurse practitioners, and today we're going to be talking to you about key survivorship issues. And remember, at the end, we will have time for questions and answers, so I'll ask for the comments when we're finished with the slides, and I hope we have time to discuss anything you want to talk about. So with that, this is an overview of what we're going to be covering today. So first of all, I'm just going to give you a brief introduction into the world of head and neck cancer, including some of the treatment modalities that patients may be exposed to and may be used for their treatment. We are also going to cover long-term complications and suggested management. We'll talk a little bit about the survivorship care model we have at DFCI. And then at the end, we're going to wrap up with a case discussion led by Lindsay. So just to cover the basics here, we're going to start with a couple of definitions. This one comes up a lot in the world of cancer survivorship, and that is, who is a cancer survivor? And the way that it's defined by the NCI is an individual is considered a cancer survivor from diagnosis through the balance of life. And I really like this definition because, as you can see in the photos down below, we're talking about the very beginning of this cancer journey. We're going through the phases of treatment that they may encounter. And then we're also talking about recovery. And so that's what I'm hoping that we cover today. And certainly we can take questions about any phases of this process. Another crucial definition is, what is head and neck cancer? What are the diagnoses that fall into this category? So basically, any tumors that are occurring below the level of the skull down to the esophagus or the thoracic inlet is going to be included as a head and neck cancer. This covers things such as tongue cancer, throat cancer, cancer of the larynx, of the nose, and we're going to talk a little bit more about that. It also covers salivary glands and thyroid cancer. Right? And of these, head and neck squamous cell carcinoma is the most common, followed by thyroid and then salivary. And then we do also counter cancers of the nasopharynx, which is kind of its own distinct entity, and a few other rarer subtypes, which we won't have time to cover today. But what do patients experience? That's what my goal is with this slide here. These are some photos just showing you what a picture of a tongue cancer looks like, or a larynx cancer. That tumor all the way to the right is actually on the vocal cord. That's what we're looking at there. And that could affect somebody's voice. And then another common way that patients present is with an enlarged lymph node or a swelling in their neck. But this is head and neck cancer too, right? People have symptoms from the cancer. That might include bleeding, or pain in the throat, or trouble swallowing, a hoarse voice. And sometimes these symptoms, or even just the cancer, also contributes to weight loss. Right? So this is the way that people are feeling a lot of times when we meet them in the clinic. I do want to point out that having this cancer diagnosis does sometimes have a nice silver lining, and that is that there's a large proportion of these cancers that can be cured. And so you see here in these pictures, just the breakdown between the early stage of the disease, the more locally advanced, as we would call it, or regional, kind of intermediate stage, and then distant disease, which is a more advanced case of head and neck cancer, which of the three is the lowest percentage rate overall. And I also wanted to point this out because when you look at, for example, this intermediate group, this regional spread of the tumor, the outcomes can still be very good. So a 2-year progression-free survival, or 2 years being the measured point without any cancer and with being alive, essentially, can be as high as 90%, or even better than that, 98.1% in a recent trial that was reported in the last year. So again, depending on the risk factors that are involved, the outcomes can be quite favorable, and people can live a long time, which is a good thing. But let's talk a little bit about this cancer journey, because it's not always an easy road to follow. And so what I wanted to show here is that for somebody that's starting on this process, it might seem like a really long road that they have to go down. And there's a number of different types of treatments that we use, and that's what's shown here kind of in the middle with the radiation or surgery or systemic treatments such as chemotherapy. And maybe they get a combination, potentially even all three, right? And we're going to talk a little bit more about that later on. There can also be different outcomes from the treatment that patients receive. So on the right, we're looking at kind of a mix of what we might expect. Number one is where we want everybody to be. This is somebody who goes through their treatment and is able to recover to the point where they're out with their friends or their family, they're enjoying foods that they had preferred before, they're exercising, feeling well again. Sometimes, though, we are left with complications from treatment, and that's what's shown down below that. Feeding tube might be necessary, a tracheostomy might be necessary. And this is a different way of living, especially if it's a long-term complication. And we'll talk a little bit more about that too. And for some patients, they have multiple rounds of these types of treatments. Maybe the cancer comes back and they have to go down this road again. And so there's really different ways that things can progress over time. But certainly we're all striving for number one as the outcome we'd like to see. I want to talk a little bit more about these types of treatments that patients encounter, because that does have long-term impact on how they feel. And so starting with surgery, a couple of different pictures here to cover. On the left, we're looking at a picture of what's called a partial glossectomy. This is removal of a piece of the tongue, and sometimes that can be replaced with what we call a flap, and we'll talk about that again in just a second. Down below that, we have a picture of a tracheostomy, and this might be needed for somebody that has a larynx cancer, for example. And then there's some pictures here of a procedure called a maxillectomy. If the tumor is on the roof of the mouth or involving the teeth, for example, we may need to take that area and remove it surgically, and there's different ways of doing that. And then thyroidectomy. For patients who have thyroid cancer, they may have a partial thyroidectomy, they might have a complete thyroidectomy. But no matter which surgery or procedure we're talking about here, they can be morbid. But I think I also want to point out that these can be curative, which is why they're done, right? And so I mentioned flap repair, and this is something that's been around now for some time, but is a little bit more recent than perhaps decades ago. This is when you take a piece of the body, sometimes it's skin or muscle tissue from the forearm or other site, and it gets sewn into the tongue to replace the piece that's removed. And this can actually result in a functional improvement. There's a structure there now with this type of surgical technique. And so patients who have either a partial glossectomy or sometimes a little bit more extensive than that, they may have a flap repair to help them with their speech and to help them with their swallowing. Another more advanced surgical procedure is something called a tracheoesophageal voice prosthesis. This is something that's done for somebody that has a tumor, usually of the larynx, where the voice box needs to be actually removed. It's called laryngectomy. And you can have this procedure done afterwards that will allow the patient to actually communicate with speech, and it is intelligible. It will sound altered compared to if they had a functional intact larynx, but it's fully formed words that almost everybody, not everybody, can understand. And the way that it works is that there's this little device that's placed on the outside of the neck, and by pressing that, it creates vibrations when a person tries to speak, and that allows for the sound articulation to be generated. And so these have been very welcomed advances in the field of surgery that have helped improve the quality of life for many people. And then there's also another option, which really started coming about in the 1990s with this clinical trial that was done. It was a large phase 3 study where they compared the outcomes for patients receiving surgery to patients who were being treated with chemotherapy and radiation at the same time. This is specifically for patients who had larynx cancer. And what they found is that in both treatment arms, the patients lived for the equal amount of time. They had the same overall survival. However, if you got treated with chemotherapy and radiation, 64% of the time they were able to keep their larynx long term, right, and still have a functional voice. And so this really shifted the way that we do things in the world of head and neck cancer, where more patients are receiving chemotherapy and radiation as a curative form of treatment nowadays, at least particularly for a cancer at that site, the larynx, for example. So what does chemotherapy and radiation look like? Well, if this is the treatment modality that we use, person's going in for radiation treatment 5 days a week. This is usually over a course of either 6 or 7 weeks. And although the treatment itself on the machine might take just a few minutes, it's at least 30 minutes that they come in, they get set up, and they receive their treatment every day. But then they also have the chemotherapy to receive. And so once a week, or sometimes once every couple of weeks, the person will come in, they'll be seen by a provider, they'll have their labs checked, and they will receive chemotherapy. And so this adds about another half a day for each chemotherapy session. And so again, they're doing this for 6 to 7 weeks. And so with that being said, I want to now shift into that world of chemotherapy and also other types of systemic therapies, because chemotherapy is not the only type of treatment that we use to treat head and neck cancer. And nowadays we're using more and more immunotherapy as well, particularly now even in the curative setting. And for thyroid cancer, and sometimes for salivary gland cancer, we might be using pills that are called multi-kinase TKIs. They have multiple targets that they're going after. And there can be different side effects depending on which treatment modality is chosen. So the chemotherapy side effects are shown on the left, and the side effects of immunotherapy really can affect any part of the body, with some being more common than others. And then for multi-kinase TKIs, there's a number of side effects listed here, many of which are skin or gastrointestinal types of toxicity. And the reason I'm showing this is because I think somebody that's been on these drugs, they may have potentially long-term side effects related to the treatment, or even the short-term side effects that they then have to recover from. It's worth knowing about, and this really guides what we do in the world of cancer survivorship. I also wanted to point out that thyroid cancer is managed differently from other types of head and neck cancer. And so surgery is really the mainstay for curative thyroid cancer. And oftentimes this will be followed by a form of radiation for a particular form of the thyroid cancer, which is most common. and we call that differentiated thyroid cancer. That's the DTC shown here on the slide. These patients will take radioactive iodine, and that is also a form of treatment for thyroid cancer. And in addition to that, if they have this type of cancer, they would also be on high doses of thyroid hormone. That's the levothyroxine, because we want to suppress the drive to make this in the body. That's actually a growth pathway for these tumors. And most of these patients will not be getting treated with chemotherapy and radiation. So they have a different type of survivorship and recovery, and we see them all. All right, so now I do want to shift gears. Where I talked a lot about different types of treatment that patients with head and neck cancer might be exposed to. And we've talked a little bit about the side effects and complications of that, which I think is really setting us up to now focus on recovery and what that might look like. And so that's really the next phase here. And that too can be a long road for somebody, particularly if they have long-term complications. So this is what everybody wants. Usually, when they finish their treatment, they want to feel great. They want to be back to eating and drinking whatever they want, enjoying themselves with family and friends. And I wish that I could promise this to everybody on day one, because, man, that would make my life a lot easier. But unfortunately, a lot of times what we are dealing with is a picture that looks more like this, where somebody is really still actively recovering from their treatment. And they may have a hard time swallowing or pain with swallowing. And so maybe their diet consists of liquids, for example, and they might feel fatigued from radiation, and they might not want to get out of bed. And so this is a lot of times, this is where we're actually starting after those curative treatments are finished, but we try to get back towards that idealized day one. And so there's this road to recovery, right? This slide here kind of outlines what we expect to see, particularly for patients who have received radiation treatment, but also in some ways, even for surgery or other systemic treatments. We see within the first couple of weeks of finishing that we do get a significant amount of recovery. And that's during weeks 1 and 2. But then after that, the recovery really slows down. And it can take months or even years to try to get back to that idealized day one. And for some patients, unfortunately, some of the complications will never really be able to fully recover from. So it's a lifelong journey. And why is that? So that's because the short-term things wear off quickly. That's why they're short-term. That's symptoms like nausea or having low blood counts and having that increased risk of infection or bleeding. But then once those things wear off, we're much more focused and aware of these longer-term complications. That might include altered taste, dry mouth, trouble hearing, or maybe peripheral neuropathy, some numbness or tingling or even pain in their extremities. And that takes a much longer time to heal. This is a long list of a lot of those long-term complications. We're not going to have time today to go over each one of these in great detail, but I want to point out how difficult this journey can be for people, especially if they have multiple long-term complications that they're dealing with. I've highlighted a few of them. These are the ones that I find to be more prevalent, and certainly we are familiar with managing on a regular basis. And we are going to talk about these ones in particular in greater detail. I also highlighted mental health, which is, I think, oftentimes overlooked, and I don't think it should be. I think that having anxiety and depression and dealing with the recovery process can really be a big factor for people. But let's start with ototoxicity. This is a side effect affecting the ears, and it could either be hearing loss or ringing in the ears, tinnitus. There are a few different things that may increase or decrease the likelihood of this happening. So, for example, if a person is treated with platinum chemotherapy, they're going to be much more likely to develop this type of side effect. But even if they only receive radiation, they could still have damage to these structures. And it's also worth noting that the type of chemotherapy matters, even within the world of platinum drugs. So cisplatin, which is the most commonly used chemotherapy in head and neck cancer, has a rate of ototoxicity of about as high as 50%. Right? Almost half of patients can have some form of this. Whereas if we choose a different chemotherapy, like carboplatin, for example, it's a much lower rate. But there could be other downsides to doing that. And there's a whole rationale for why the chemotherapy is preferred and why it's not. This type of side effect is often permanent. I will say that the tinnitus can improve over time. I've had many patients where that decreases in frequency, but hearing loss is usually a permanent side effect. And we don't have any good ways of preventing this, not that are FDA approved at this point. And the other reason this is so important is because hearing loss has been linked to cognitive impairment. Right? And so I think it's really important that we identify this early on. We send patients for a hearing test. This is an audiogram. And if they need some sort of amplification device, we supply that because we want to prevent that long-term risk that maybe this could contribute to cognitive impairment over the course of their life. Right? So these are things we can do to help. What about peripheral neuropathy? This is another common side effect of chemotherapy, often described as pins or needles in the hands and feet. Sometimes, when it's a little more intense, patients might describe this as a burning type of pain that they feel, particularly at night. And if it's severe, it can even affect somebody's ability to feel on balance when they're walking or to hold on to objects, as a picture shown here of somebody dropping their phone. Right? And that's what we really want to avoid and minimize as much as we can. The incidence is shown here ranging somewhere between 8 and 38% for patients treated with head and neck cancer. And there's a much higher incidence if chemotherapy is used before radiation or before surgery. We call that induction chemotherapy. This tends to be closer to that 30% range. It's usually early grades, grade 1 and 2, right, where it's not severe. This is like a mild and moderate type of symptom. Rarely does it get into the grade 3 severe range, but it does happen. And it might improve with time, and it might even go away, especially if it's a more mild case, it might disappear entirely. But for people that are having pain in particular, there is a medication called duloxetine that can be helpful. This has been studied in clinical trials, can help improve pain. And then there are other interventions that have less data behind them, but have low risk for harm as well. And that includes things like exercise, acupuncture, which most people are probably familiar with, acupressure, where you're actually applying pressure points instead of introducing needles, and something called scrambler therapy. And then what about fertility? This is another potential long-term side effect. This type of cancer can affect a younger generation as well as people that are older age. And for some of our patients, they have interest in having a family, and we need to be thinking about fertility preservation. So it's very important that we counsel people on this ahead of time because the exposure to chemotherapy will decrease their risk of fertility, especially drugs like cisplatin that we use can have these types of long-term effects. And it can affect both men and women, right? So we need to pay attention to that as well. A lot of what we do is identifying patients early on to try to prevent trouble later on, whether that means referrals for cryotherapy to preserve either the sperm or the oocytes, or if that's not chosen, there is an interest a lot of times in using hormonal therapies to try to preserve as much as we can the functional fertility long term. Oh, okay, I jumped too fast. It's a little bit of a delay. So we're going to go back to this slide, which is xerostomia or dry mouth. Right? This is another very common side effect, mainly caused by radiation treatment, but there are other factors as well, including some of the medications we use. And it can have a slow recovery. So the mechanism here, again, for the most part, is somebody receiving radiation, which can be damaging to the salivary glands. There's also a risk if somebody has a salivary gland removed, they may have some risk of xerostomia. And what I really wanted to highlight is this graph in the middle of this slide, because if you look at it all the way on the left, we're seeing where people start with their saliva production. And during treatment, see the first time point is 5 weeks in, we see that saliva production dramatically decreases. And this is in the middle of treatment if you're receiving radiation. And then the recovery is not quick, it's slow, and it takes months to recover. And even at 1 year, which this went to 52 weeks, but even at that time point, people were reporting 50% recovery of their salivary production. And so for many of my patients, they never feel like the saliva production ever gets back to normal. But most of the time, they'll get enough of an improvement where they can find ways to live with this. And that might just include something like drinking water frequently. But sometimes it also includes using a saliva substitute. They have lozenges, sprays, and rinses that can be tried. And if it's really severe, we will think about cholinergic drugs like pilocarpine or cevimeline. And the reason we usually wait to initiate these is because number one, a lot of the recovery takes about 6 months to even happen. Right? So we want to give somebody a chance of recovering on their own before we start giving them medications that they're going to take every day. And then on the other hand, we also know that these medicines can cause symptoms that sometimes are worse than the reason that we're using them to begin with. That includes things like sweating or nausea or diarrhea. And so I always tell people that are on these medicines, if the medicine is making you feel worse than before you even started it, there's no reason to be on it. Right? We need to stop that. It's important to always have those conversations. Another side effect is osteoradionecrosis. This is, again, mainly a radiation-induced side effect. The mechanism is radiation that damages the blood supply to the bone, and in particular, we're talking here about the jaw. And we can identify this by seeing in somebody's mouth exposed bone. That's what the picture is showing you with the arrow. That's also what the picture next to that is showing you. It's a bit more obvious because it's more advanced in that case. And this can be either asymptomatic if it's early on, or it can be painful. And sometimes there's also sensory changes, some numbness associated with this. And so when it becomes more advanced, there are other things that we can do. But at a minimum, we want to encourage good oral hygiene. And we can use things like chlorhexidine rinse, which is an antibacterial type of mouth rinse. That helps minimize. But if it's more advanced, we may be talking about surgery, maybe a minor surgery. But if it's severe pain or a large portion of the bone is involved, it might be more of a major surgery where a piece of the mandible has to be entirely removed. Right? And so we're looking for this in our clinics. And if people are having pain after they finish their treatment, we want to be mindful of this possibility. The other thing that we're always thinking about is if they're having new pain and they're having these types of symptoms, could this be cancer? And we need to rule that out. And that's another reason I feel like we need to see patients in survivorship to identify this possibility. How about lymphedema? This is another commonly encountered side effect, and it can be long-term. So what we're looking at is the swelling that develops primarily under the chin and into the neck. And this is a complication of either radiation or surgery. And for some patients who have both treatments, the risk is even higher. It's reported to be 75% incidence rate. There are different stages. So it may be barely noticeable at all. It may be dramatic. And if it's advanced and we don't treat it, it can become firm. All that fluid that builds up in the neck can harden over time and lead to irreversible tissue changes, which can restrict neck mobility. So we really don't want it to be severe. And if we identify it, we want to manage it. So what do? There are people that are called lymphedema specialists. And these are usually physical therapists who have been trained to manipulate the lymphatics by massage to drain the fluid out of the neck and into the chest cavity. There are also compression bandages, which have shown some effects for managing this. And there are devices such as the one that the person on the right side of the screen is wearing, which actually provide like a pneumatic compression to move the fluid via machine, essentially. And this is something that they would generally wear every day. And I don't think we can finish this talk without discussing feeding tubes and tracheostomies. So not everybody gets this type of procedure. That's something I always tell people that are asking about this, because that is sometimes the perception is that if you have a cancer of the head and neck, you're going to need a feeding tube, and you might even need a tracheostomy. And the reality is that not everybody needs to have this done. We have a threshold for placing feeding tubes, at least at Dana-Farber, and a lot of other places do too, where if you're able to maintain your weight and you haven't lost at least 10% of your weight, you might be able to get through the treatment without using a feeding tube. Of course, if the opposite is true, you might need one. But thankfully, a lot of the times, this is a temporary procedure. The goal is to place the feeding tube, get you through the treatment, and then when you're able to eat and drink again, remove the feeding tube. That doesn't happen for everybody, and certainly there are people that are living with long-term feeding tubes after their head and neck cancer diagnosis. Right? But I don't want people thinking that this is the reality for every patient. And there are ways to teach family and other caregivers how to manage these. And I think a lot of times people become very comfortable even managing it on their own, if that's, in they're placed by specialists in GI or surgery or interventional radiology. And these are the teams that help if there's trouble along the way, if there's a problem with the feeding tube, for example. On the other side of the screen, we're looking at a picture of a tracheostomy. Again, not everybody needs this. I would say they're much less common than feeding tubes. And they are typically placed in one of two circumstances. Either it's a planned part of a surgical operation, maybe because the larynx has been removed, or because there's a lot of swelling anticipated with a major surgical procedure and they're going to need a temporary airway, or the tumor itself is actually impacting the airway and there's an emergency where we don't think the person's going to be able to breathe unless they have a tracheostomy placed. And so those are the two ways these are usually determined. And in some cases, they're reversible. And so it's not always a permanent procedure. So for some of our patients, this will be a temporary thing that can then be corrected later on. But not everybody has that option either. And so we have patients that are living with these long term. If there's a complication, there's a problem with it, it's typically managed by the head and neck surgeon who placed a tracheostomy or would be familiar with this type of care. And then psychosocial health. I told you mental health is a huge factor for people. That's because there's so many different things that they might be thinking about. They may have symptoms of depression. They may have distress from a variety of reasons, including altered appearance or the management of a feeding tube, for example. They have worries and anxieties and fear that their cancer might come back, right? And these are concerns that can be long lasting, can be chronic for sure. And we need to address them too. And importantly, I also want to highlight here at this time that there's a high risk of suicide in this group. It's actually 2 times higher compared to other types of cancer, just in terms of how frequent it is. And I think a lot of that has to deal with the things you're seeing on the left-hand side of the screen, the symptoms and the fears and the concerns that people are having. And so we really need to be assessing for distress. We need to assess for depression, anxiety at each visit, and then offer appropriate counseling and pharmacotherapy if indicated. Okay, and so I hope, after presenting all of this, one thing that you would understand is that treating somebody with head and neck cancer really requires a team. There are so many specialists that can be helpful here. And that goes way beyond the physician, nurses, and advanced practice providers who are really at the core of this. but we also have dentists, audiologists, speech language pathologists, dietitians, pharmacists, physical therapy, occupational therapy, social workers, and the survivorship team, right? And so with that, this is where I want to now segue into this later part of our talk, and we're going to have Lindsay discuss what cancer survivorship looks like at Dana-Farber.
Thank you, Dr. Dennis. So again, I'm Lindsay Margolis, a nurse practitioner, and I see patients in our survivorship clinic, as well as through treatment. So today I want to share two real examples of survivorship patients that I've seen in our clinic. So looking beyond the treatment choices and really focusing on what happens afterward, how we help our patients return to daily life, manage any lingering toxicities, and how our survivorship visits help to coordinate long-term health needs. Dr. Dennis, I may need you to move forward on the slides for me. Thank you. I'll start with an overview of a survivorship visit. So as Dr. Dennis mentioned, even though survivorship really begins at diagnosis, the first formal visit usually occurs at least 6 months after treatment has completed. And at this visit, we'll review the treatment history, whether patients got surgery, radiation, chemotherapy, immunotherapy, or a combination of those things, to anticipate what toxicities they may have dealt with or are still dealing with, and guide our surveillance plan. So we ensure that follow-up is happening on schedule, assess new or persistent symptoms because problems often evolve after treatment has ended rather than during. We do a focused physical exam and then create a survivorship care plan, summarizing risks and recommendations. And then we share that with the patient and also with their primary care provider. So that long-term care of the patient becomes a shared responsibility. Next slide. All right, so our first patient is a 35-year-old woman who is diagnosed with squamous cell carcinoma of the lateral tongue with high-risk features. So she completed treatment with 2 surgeries, had immunotherapy, chemo and radiation with immunotherapy, and then a course of immunotherapy after that. So quite a lot of treatment. This patient works full time, lives with her partner. So she's young and busy and wants to get back to her normal life as quickly as possible. And that context helps to kind of shape a lot of our survivorship discussions. Young patients in particular often experience really intense toxicities during treatment, which I'll talk a little bit more about, things that Dr. Dennis already spoke about. And also because she's in that young adult age group, fertility planning is also part of the discussion before treatment and also during survivorship. Ideally, those fertility discussions happen before treatment, and then we continue them after treatment ends. Next slide, please. So due to her high-risk pathology, this patient received treatment after surgery, but these decisions can happen really quickly. And so there's often kind of a narrow window. And in this patient, a major consideration was fertility. So we're able to get a consult with reproductive endocrinology pretty quickly within 3 days, because if you don't provide that option quickly, the decision can effectively be made for the patient. So we try to get them in as fast as possible. This patient ultimately elected not to pursue egg retrieval or ovarian tissue preservation, but we still acted to reduce risk. So she received Lupron, hormone therapy during chemo for ovarian protection. But that comes with its own toxicities. Hot flashes are a major toxicity there. So we give norethindrome add-back therapy to help kind of reduce those side effects while patients are undergoing treatment. So the toxicity profile for this patient included things like immune-mediated hepatitis, mucositis or mouth sores, thrush, tinnitus, weight loss, and anxiety. And these things all become central to her survivorship plan after treatment ends. So just because treatment's over doesn't mean we ignore those issues. All right, next slide, please. Now that she's completed therapy, the survivorship visit is really about anticipating what comes next. For head and neck cancer, the surveillance plan is more than just imaging or a physical exam. We often do scope exams on our patients every 3 months at first, and then spaced out a little bit further after the end of treatment, because recurrence isn't always visible externally. Dental health is a major focus of our visits. So after radiation, our patients need dental visits and dental cleanings every 3 to 6 months, daily use of fluoride trays or prescription fluoride paste. We screen for dry mouth or xerostomia and counsel on avoiding non-urgent dental extractions due to the risk of osteoradionecrosis. We screen for things like hypothyroidism and then follow her ototoxicity to make sure that her symptoms have resolved and refer to audiology if the symptoms are persistent after the end of treatment. Next slide. Again, many of our patients develop lymphedema of the neck or the face, so we try to refer pretty early for that specialized therapy. Patients also can have neck tightness or shoulder dysfunction from radiation or surgery, so those patients will refer to PT or OT. As far as fatigue and deconditioning, we'd love for all of our patients to exercise, but instead of telling them to just exercise on their own, in our survivorship clinic, we do try to connect them with cancer-specific programs. So things like the Zakim Center here at Dana-Farber, or the Livestrong program at the YMCA, which provide safe and structured rehabilitation for cancer patients. And then again, we follow up with fertility post-treatment. And coming back to the mental health concerns, anxiety during treatment can be a signal that we need to be really proactive in the survivorship setting. For many of our patients, the emotional impact of their cancer can become even more obvious once treatment is over. Life is supposed to feel normal again, and they're still having these chronic and lingering side effects. Next slide, please. So a few things just to wrap up this case. Young adults with head and neck cancer have unique survivorship needs, often have really intense toxicities that drive our survivorship discussions. Fertility should be discussed early and often. Proactive symptom management can improve their long-term outcomes, especially from a symptom perspective. And clear care pathways from the beginning can help to reduce uncertainty and anxiety once treatment ends. All right, we can move on to our next case study. Our second patient is a 63-year-old woman diagnosed with sinonasal undifferentiated carcinoma. She lives with her adult children, not currently working. She completed treatment with induction chemotherapy and then concurrent radiation and chemotherapy, and presented for survivorship care. The predominant symptoms that were continuing to affect her quality of life 1+ years out from the end of treatment were things like dry mouth, ringing in the ears or tinnitus, and neuropathy, which are classic long-term issues in this population. Next slide. So during her induction chemotherapy, she developed neuropathy and tinnitus, which we attribute to cisplatin. So that guided our treatment decisions for the second part of her treatment to minimize some of those side effects during curative care. And her long-term toxicities now define her survivorship care. So the neuropathy, the hearing loss, taste changes, dry mouth, these alter the way she lives her day-to-day life. Next slide, please. So for this patient, we'll focus on 4 major issues in her survivorship care plan. Xerostomia or dry mouth. She's managing with over-the-counter saliva substitutes, but like many of our patients, is hesitant to try prescription medications because of the concern for side effects. So it's important that in survivorship, we validate those concerns, discuss low-dose options or non-pharmacologic options, reinforce that controlling these symptoms is often just trial and error. In terms of peripheral neuropathy, her neuropathy is positional, worse at night. Her PCP had recommended wearing arm braces. And then we referred her to acupuncture at the Zakim Center here at Dana-Farber. So this is a really good example of how non-medication, non-pharmacologic interventions can help improve comfort and function for our patients. For ototoxicity, she was referred to audiology during treatment, but continues to follow with them for both ringing in the ears and hearing loss. Now qualifies for hearing aids. So we try to make those referrals early and also can help patients figure out how to afford things like hearing aids. And then fear of recurrence was a big one with this patient and with a lot of our patients. It's really common, especially when these chronic symptoms that patients have, even a year plus out from treatment, serve as a constant reminder of their cancer and of their treatment. So our role in survivorship is reassurance, creating a structured follow-up plan, and then referring for psychotherapy as a first step when it's appropriate. So that emotional piece of the recovery is just as important as the physical. Maybe we can move on to the next slide. So I want to go through what the survivorship care plan actually looks like. At their first visit in the survivorship clinic, every patient receives a survivorship care plan. It's a written document that summarizes their treatment history and outlines what comes next. So it includes recommended screenings, schedules, symptom red flags that they should let us know about, self-management strategies, and then considerations for the primary care setting. So things like thyroid monitoring or dental precautions. And importantly, this document is shared with both the patient and their primary care provider because survivorship is a shared responsibility. So it's not just a referral back to primary care. We all work together to support the patient after treatment. So a few key takeaways to close out this case. Long-term toxicities are common and they require multidisciplinary management. Non-pharmacologic strategies like acupuncture, braces, hearing aids, and oral care strategies can make a real difference in our patients and their symptoms. Fear of recurrence is universal and often needs really structured support that we can provide in survivorship. And again, those clear survivorship pathways from the beginning of treatment, from diagnosis, help reduce uncertainty and help patients live better after treatment ends. So with that, we'll take any questions that you might have.
Thank you, Lindsay. That was great. It's really good.
Thank you both so much for that great presentation. As mentioned, if you have our live audience have any questions, please feel free to put them into the chat or the Q&A, and I'd be happy to moderate for our two presenters. So maybe we'll give it, if it's okay with you both, a few minutes for any questions, if that works for you.
Sure.
Yeah, while we wait, Lindsay, I'm curious actually. Do you have any insight? What has surprised you running our survivorship clinic? Meeting with patients in terms of what their needs are, or how we can support people better. I'm curious just to get some of your thoughts on that.
Yeah, absolutely. I'm often surprised at. I guess it's not surprising, but our patients when they make that transition back to primary care or seeing their primary care regularly. These are still relatively rare cancers in the general population, and primary care doesn't always know what to look for or what they should be screening for or what the recommendations are for how to treat these treatment-related side effects. And so I think it's been really valuable to be able to present patients and their primary care providers with something concrete that helps give them a plan for continued monitoring so that we can work together.
I think that's really important. And one thing that I'll just follow up on with what you said is that some of these diagnoses are actually very rare, in particular salivary gland tumors or some of our other types of head and neck cancer. And I think for a lot of people dealing with that knowing that this is a rare cancer, they feel isolated. They feel like there's not anybody that really understands their situation. Even their doctors sometimes don't know the best things to tell them because they just don't have experience with that. And that's perfectly understandable. That's why they get referred in, to Dana-Farber or other sites. But I think that's another thing that people are, dealing with in their life. They don't always know, if they're on the right path, for example, right? This just adds to that mental health piece.
Yeah, absolutely. And I think I hear a lot from patients in survivorship, how often they think about their cancer because they're having these chronic side effects that often are happening every time they swallow. They might have pain, or they're constantly hearing a ringing in their ears. And so that's different from some other cancer treatments where the side effects aren't as persistent or as obvious, and don't impact everyday life as much. So our patients are thinking about their cancer a lot, even after they've been cured.
Very much so. I do see a couple of questions coming in the chat. So the first one is from Lorraine. Thanks for asking the question. This is a question about radiation. She says this person has previously received neck radiation, and they want to know if they can receive radiation on the other side of the neck. I will just caution, that I'm not a radiation oncologist. However, in my experience, this has not been a limitation. You would need to meet with a radio oncologist to be sure, because they need to go over the radiation plan, right, to see where the radiation was delivered and if there's overlapping sites. But I would not say that this is a definite contraindication. And in fact, in my world, a lot of times patients who had radiation may need a second course of radiation. There is such a thing as re-irradiation, and that has a whole other world of potential side effects when you have to do radiation twice. But I think it's an important question to ask and discuss with the person that specializes in that. Another question here came in: do we hold support group sessions for patients? And there's an answer for that. So there are formalized support groups that people can be connected with. I personally don't hold one. I don't think Lindsay's involved in that right now. It's usually led by a social worker, but there are different ones that are even independent from that. And so if people are asking for this in our clinic, for example, there are some referrals or references, that we can direct them to. It's a good question, because I've heard that actually from some of my own patients. They want to know, is there a group that they can meet with? It's actually especially important, I feel like, early on, before they even start the treatment. That's where a lot of interest is as well, is are there people that have been through this before that I can talk to, because that's helpful. I've heard positive feedback when they've been able to connect with people in the beginning as well. It's a great question. Thank you for asking that. Any others?
I don't see any others right now. Just want to tell our audience, thank you all for joining us, and thank you, Lindsay and Dr. Dennis, for your time and expertise today. We really appreciate you coming on. This was a recorded session, and it will be edited and published on our YouTube page, so please feel free to check that out. It usually takes a couple weeks to do. And for any other additional questions or comments, you can definitely reach out to us on the Blum email, and I'd be happy to send it over to our two presenters if there was any additional questions. Thank you all for joining us, and that concludes our presentation today.
Thank you.
Thank you.